The views and opinions expressed on My Story Living with Lupus podcast represents each person's individual experience. By listening to this podcast or reading our blog, you agree not to use this podcast or blog as medical advice to treat any medical condition in either yourself or others. As always, consult your own physician for any medical issues that you may be having. My Story Living with Lupus podcast is officially trademarked, all rights reserved. Thank you for joining me for another episode of My Story Living with Lupus podcast. I'm your host, Susan Hendricks, and I'm so glad that you could join me on this Monday, December 14th, 2020. On today's episode, I'll be talking about Real-World Study Affirms Efficacy of IV treatment with Benlysta for lupus. Also, age at start of menstruation and breastfeeding linked to lupus risk in Black women. So you know what I want you to do. That's right, from the United States to Lombardy and Piedmont, Italy. Get ready to grab that cup of coffee, that cup of tea, and to my listeners late at night, now you know I appreciate you. So get ready to grab your favorite glass of wine and come on and join the conversation right here on My Story Living with Lupus podcast. We all know the benefits of apple cider vinegar. Now, you guys know that I'm a vegan and that I have lupus along with other health issues. I used to take ACV every morning before I worked out, but eventually the taste of ACV got to me and I had to look for another alternative. And that's when a friend of mine turned me on to Goli. Goli is the first apple cider vinegar gummy. They give you all the benefits of ACV without the taste. That's right. Goli is vegan, gelatin-free, gluten-free, and 100% organic. And the vitamins and the ACV in Goli promotes a healthy heart by maintaining a healthy cholesterol range, controls blood sugar levels, and also curbs your appetite. And the best part about Goli, for every cell generated, a child in need receives a 6-month supply of essential vitamins with Vitamin Angels. So, if you don't believe what I'm saying, I'm going to give you some information so you can try Goli for yourself. Here's a promo code you can use. It's SULYN1. That's SUELYN1. 10% off of your initial purchase. Also, I'll leave a link in the description in the podcast. So, why don't you go and try it for yourself? You won't believe how good it tastes. That's Goli. Thank you so much for joining me on this Monday, December the 14th, 2020. I know that I usually place an episode on Fridays, but this time I didn't. And at the end of the show, I will tell you what has been going on with me. But I want to thank you for joining me this morning, this afternoon, this evening, wherever you may be. Now let's get started discussing real-world global study affirms efficacy of intravenous treatment with Benlysta for lupus. Now, Benlysta has been proven effective for lupus disease activity and is associated with lower use of glucocorticosteroids, better known as GCS. Now, data from 830 people with lupus in 6 countries that were taking Benlysta and participating in the OBSERVE program were reviewed. The participants took the drug as part of their standard therapy, and their clinical responses, disease activity, and GCS use were noted. Nearly half of the group saw improved disease activity, and 13% achieved near normal conditions. Those taking Benlysta while on GCS also saw improvement at month 6. Results were broadly similar on a country level. However, Switzerland and the United States saw a shorter disease duration, 45.3 and 55.7%, compared with 23.1% in Canada and 39.7% in Argentina. And more patients from Switzerland had mild disease, 43.4%, when they began Benlysta treatment, compared with 2.8% in the United States and 10.5% in Argentina. The large multi-country study further underscores intravenous, that means administered through the vein, Benlysta therapy as an effective treatment for lupus. Before making any changes to your medication, always consult with your physician. When we return, we'll discuss what was exactly in the research findings. So stay with me. Ophthalmology Associates, PC, Drs. Berman and Dr. Zuckerbrod, treating diseases of the eye and eye surgery. You can reach them at 313-341-3450. You know what, you guys? I'm sitting up here recording, and guess what? I didn't even have my mic plugged in. It's gonna be one of those days, but I will get through it. Now, so if you hear two different sounds, that's because I did not have my mic turned or plugged in, and I was just recording away and it was coming through the computer. So I don't know what's wrong with me today. But hey, let's get started talking about the research that was performed on real-world effectiveness of Benlysta treatment of systemic lupus erythematosus. Systemic lupus, better known as SLE, is a chronic autoimmune disease with various clinical presentations and typically a relapsing remitting course. To manage disease activity, patients with SLE often require lifelong medications such as anti-malarials and immunosuppressive agents, in addition to oral glucocorticosteroids, better known as, that's right, GCS, to prevent and treat flares. Now, patients with SLE have elevated levels of B-cell activating factors, better known as BAFF, and also known as B lymphocyte stimulators, which promotes abnormal B-cell activation. Now, Benlysta is a human immunoglobulin monoclonal antibody that inhibits the activity of BAFF and is licensed for the treatment of adult and pediatric patients with active autoantibody positive SLE who are receiving standard SLE therapy. The efficacy and safety of Benlysta in patients with SLE has been demonstrated in several randomized clinical trials. However, the strict inclusion and exclusion criteria and requirements for consistent medication use can limit the generalized ability and interpretation of the findings of clinical trials to the real-world SLE patient population treated in everyday clinical practice. Furthermore, determining whether improvements in clinical trial composite endpoints translate into benefits and routinely assessed clinical outcomes based on physician judgment, provides valuable information for physicians and patients when making treatment decisions. Now, consequently, the real-world effectiveness and utilization patterns of intravenous IV Benlysta in patients with SLE have been evaluated in several countries in the observe, which is evaluation of use of Benlysta in clinical practice settings program. In those observational studies, adult patients with SLE treated with Benlysta in a clinical practice setting demonstrated consistent clinical improvements. However, with the exception of the United States, which included less than 500 patients, sample sizes were small, 50 to 100 patients, limiting the ability to explore patients' subgroups or factors associated with treatment effects. Now, the aim of this post hoc analysis was to pool individual patients' data from the observed study to further evaluate the real-world effectiveness and utilization of Benlysta in a large sample of patients with SLE. Now, the physicians had to complete eligibility criteria for each individual observed study, which has been published. In brief, rheumatologists and or internal medicine specialists who prescribed Benlysta to patients with SLE as part of their usual clinical practice were invited to participate. Physicians extracted patient information about demographics and disease and treatment characteristics. All patient data were anonymous. Now, for patients, the current analysis included all patients from the individual observed studies. The following patient eligibility criteria were used in the primary studies. Adults 18 years of age with a diagnosis of SLE who were prescribed Benlysta as part of a standard SLE therapy, who initiated their Benlysta therapy 6 months prior to study enrollment. Argentina, Germany, Spain, and Switzerland, or had received 8 Benlysta infusions during the 6 months prior to study enrollment. Canada and the United States. And for whom reasons for Benlysta initiation could be identified. Patients enrolled in an SLE clinical trial or who had initiated Benlysta as part of a clinical trial were not included. Now, in Observe, Argentina, Canada, Germany, Spain, and Switzerland, Physicians examine their patients' records to identify all patients with SLE receiving Benlysta. To avoid selection bias, all patients who met the eligibility criteria according to each country's indications were selected for inclusion. In Observe US, a random sample of eligible patients was selected by retrospective chart review of all available patients for each individual study center. Now, the endpoints and assessments. The primary endpoint, physician assessed overall clinical response to Benlysta at month 6, was evaluated as worse, no improvement, 20% minimal, improvement 20 to 49%, clear but moderate improvement, 50 to 79% large improvement, or 80% near normalized improvement compared with index. Now, the patient's demographics, age, gender, country of enrollment, and clinical disease severity and duration, number and type of SLE manifestations, number of comorbidities, and treatment characteristics at Benlysta's initiation were described as part of the secondary endpoint. Now, secondary endpoints at month 6 versus date of Benlysta initiation also included physicians assessed overall clinical response among patients in high disease activity subgroups, patients' characteristics associated with a 50% improvement in physicians assessed overall clinical response to Benlysta, change in SLE Disease Activity Index 2000, safety of estrogens in lupus, National Assessment SLE Disease Activity Index score, choice based on center preference for each individual, reasons for Benlysta initiation and discontinuation, physicians reported, and changes in GCS use. Now, change in dose, proportion of patients experiencing dose change, and proportion of patients achieving dose reduction. Today, prednisone equivalent and reason for Benlysta initiation and discontinuance. When we return, we will complete what the study says exactly about the effectiveness of the use of intravenous Benlysta. If you would like to appear on an episode of My Story Living with Lupus, you can contact us at mystorylivingwithlupus@gmail.com. Also visit us on our Instagram page and also our website, My Story Living with Lupus. All right, and we're back. I had to go make me some peach passion tea. It's by Celestial. It's really good, and I lit me up some sage, and I'm burning sage. We stopped on the endpoints, and let's go to the secondary endpoint. For the secondary endpoint of physician-assessed overall clinical response, we may have went over this, but I'm going over it again. Patients were assigned to one of two high disease activity subgroups to reflect the indicated population in Europe. Now, subgroup 1, patients with a SLEDAI 2K / Selena SLEDAI score 10, and subgroup 2, patients with high anti-dsDNA or low complement C3 and or C4, lower limit of normal based on physician's assessment of the medical record. Now, descriptive statistics were used to summarize continuous data, mean, median, and standard deviations. And when it came down to the patient's demographics and clinical characteristics, in total, 830 patients were included in this pooled analysis, with the majority being from the United States, being female, being Caucasian/white, with a mean age was 41.9, you might as well say 42 years old. Most patients were classified as having high disease activity with either a SLEDAI 2K / Selena SLEDAI score 10. The conclusion of all of this basically indicates that the use of, how can I put this pooled analysis basically demonstrated that Benlysta improves clinical manifestations of SLE and enables a reduction in GCS. The results of this study corroborate the conclusions of the individuals observed studies and confirm the real-world effectiveness of Benlysta IV in the management of SLE. So what are your thoughts on that? When we return, well, you know what? I might as well go into it now. Age at start of menstruation and breastfeeding duration linked to lupus risk in Black women. That's right. Beginning menstruation at age 15 or older and breastfeeding infants for 6 months or longer may be associated with increased risk for developing lupus in Black women. Other female reproductive factors such as age at first birth, menopausal status, hysterectomy, age at menopause, or history of endometriosis are not associated with the disease. A group of 58,243 Black women were assessed twice a year for 20 years about reproductive and other health factors. Of the group, 125 women developed lupus at an average age of 43. Those women who started their menstruation cycle at a later age, 15 versus 12, and breastfed for 6 months or more were associated with an increased risk of lupus. A study author and Lupus Foundation of America's Medical Scientific Advisory Council Chair, Karen Kostenbader, states several years ago, her team investigated reproductive factors in relation to the risk of developing lupus among the predominantly white women followed in the Nurses' Health Study cohort. They investigated a range of factors and found that early age at first period, age less than or equal to 10 years compared to average age 12, was associated with a more than doubled risk of later developing lupus. Menstrual irregularity was also associated with risk of lupus. Age at first birth, having had babies, having breastfed babies, and duration of breastfeeding were not associated. Here they collaborated with the Black Women's Health Study, which enrolled 59,000 women in 1995 to investigate similar questions as Black women are at higher risk of developing lupus. Again, they identified new cases of lupus and examined whether a range of factors was associated with lupus. They found that at later age, first period at age 15 or older, relative to age 12, was associated with a more than doubled risk of developing lupus, and having breastfed one's babies for 6 or more months was also associated with a 70% increased risk. Other reproductive factors were again not associated with lupus risk. These findings were unanticipated, but may signal that abnormalities in the timing of puberty were related to later development of lupus. Now, more work needs to be done to figure out how the timing of sexual maturation and hormonal changes may be related to increased risks of later developing lupus. Further investigation into the biological mechanisms underlying reproductive factors, and lupus is important. We all know that lupus is 3 times more common in Black women than white women. The disease occurs at a younger age and is also more severe in Black women. Stay with me. When we return, I'll tell you about what's been going on with my health. So stay with me. All right, and we're back. And I am going to tell you why I did not upload an episode of my Story Living with Lupus podcast on Friday. As you know, if you've been listening to the podcast, and since we are on Amazon podcasts and you're a new listener, I have lupus, and I was in a real bad lupus flare in November. And I said previously on the podcast that it is becoming increasingly harder for me to bounce back. Why, you may ask? Well, the type of lupus I have is systemic lupus erythematosus. It strikes every internal organ in my body. And it seems like the life is being sucked out of me, but I try to keep going. But on Friday, the fatigue and me not feeling well, it hit me pretty hard. I went to the doctor on Thursday, and the doctor was going over the labs with me. And once again, the doctor said, "Susan, do you need anyone to speak with?" And I said, "No." I said, I knew it was something going on with my blood. I also have a blood condition, several of them. A blood, I hate to say disease, but it is a blood disease. I have several of them. And right now, it was hard for them to locate not only my red blood cells, but my white ones also. So I'm dealing with that. And when you know that you have a blood, I like to say, disorder, it gets hard, you know. I woke up the other morning and I sat on the edge of the bed and I asked God to give me the strength. I had no strength at all. And I sat there for the longest, and my sister walked by my room and she looked at me and she said, "You don't feel good, you're sick." And I said, "I'm okay." got up, took a shower and everything, and if she only knew how I felt. All I wanted to do was to just rest in bed. But I know that the bed for me can take my strength. I'm just speaking of me. It can take my strength. So I said, let me get up and try to do some things. In the meantime, lupus attacked my liver. And it looks like I have inflammation of the bowels because I have not been able to eat anything solid. It'll be a month. It's going on a month now because when I do, whatever I eat comes right back out. And so I have Jell-O and I drink smoothies. Now, the endocrinologist mentioned when she seen my blood work last month, she said, Susan, I want you to think about infusions. And I said, okay, but I don't think we're going to need them. And she said, just think about it. She said, just in case you do need them. And when I went to my PCP, the PCP came with the same thing, said, Susan, think about infusion therapy. I said, I don't think that I'm going to need it. But, as I stated, I knew it was something going on with my blood, so I contacted my oncologist and I made an appointment to see my oncologist. I see my oncologist this Thursday. And I told her, I said, we'll see where we go from there. And the PCP said, did you contact the other specialists we told you to get in contact with? I said, yes, I see them on Friday. And I said, we will go from there. But if you were to see me and you can tell when I'm not feeling well, I get, you see the circles around a raccoon's eyes. My eyes get like that. That is basically what I've been going through. And I'm going to make a promise to you that I will record enough episodes in case I either have to go for infusion therapy, or if I have to go for a liver biopsy, or if I have to go for another bone marrow aspiration. There will be enough episodes uploaded for you to listen. But that has been what's going on with me. I don't let it get me down or anything, because it's just one of those things that some of us go through. And it is what it is. I keep it moving forward like I want you guys to do. But it's time for me to come to a close. And I want you to remember this. As 2020 comes to an end, this year has been a year with many ups and downs, twists and turns, a numerous amounts of pain along with heartache. While there's a great deal we could not control, there still exists an abundance to be thankful and grateful for. Lastly, I want to say this to the medical research community. There is no cure for the common cold. There is no cure for HIV. There is no cure for MS. There is no cure for cancer. And most importantly, there is no cure for lupus. If you guys can find a cure for COVID-19 in less than a year, it would seem to me that you would be able to find a cure for all that I have just mentioned. We need a cure. Time waits on no one. But we thank you for the cure for COVID-19 in less than 1 year. But there's something terribly wrong with this picture. Is it to keep Big Pharma in business while there is no cure? Is it to continue to make money off of people who are sick and need the quality health care that they deserve? We need a cure. Just like you found one for COVID-19, find one for all of those that I mentioned. I'm Susan Hendricks, your host for My Story Living with Lupus podcast. I thank you so much for joining me for this Monday episode. I will see you on Friday. Take care. The views and opinions expressed on My Story Living with Lupus podcast represents each person's individual experience. By listening to this podcast or reading our blog, you agree not to use this podcast or blog as medical advice to treat any medical condition in either yourself or others. As always, consult your own physician for any medical issues that you may be having. My Story Living with Lupus podcast is officially trademarked, all rights reserved.